Well, hello, my name is Sara Hocker. I'm a neurointensivist at Mayo Clinic in Rochester, Minnesota. It's nice to get a chance to talk with you today. I'm going to be covering the diagnostic approach in NORSE, which is new onset refractory status epilepticus, but I will also be putting it into some context as far as the presentation, outcomes, and ICU issues are concerned. The only relevant relationship I have for my disclosures is that I am an advisory board member for the NORSE Institute, which I receive no funding for. So NORSE is a clinical presentation, which is really key. It's not a specific diagnosis such as HSV encephalitis leading to status. A patient without active epilepsy or other pre-existent relevant neurologic disorder. The patient has new onset of refractory status epilepticus without a clear acute or active structural or toxic or metabolic cause. A subcategory of NORSE is FIRES. FIRES is a febrile fever preceding the onset of new onset refractory status epilepticus, and it's more common in children than adults. It requires a prior febrile infection with a fever starting between 2 weeks and 24 hours prior to the onset of refractory status epilepticus. So we'll be talking about these things together as though they're one entity. It's a clinical syndrome that the first phase lasts 2 days, 2 to 3 days to a couple of weeks. In 2/3 of cases, it begins with a mild febrile illness. It's associated with malaise, fatigue, and symptoms of upper respiratory or gastrointestinal infection. Rarely is meningeal inflammation such as headache and photophobia associated. Patients often have behavioral and cognitive symptoms in association with the onset of seizures, such as apathy or agitation, amnesia, and sometimes hallucinations. And the presence of hallucinations may suggest an autoimmune etiology, specifically anti-NMDA receptor encephalitis. The second phase of the syndrome lasts from days to several months in a minority of patients. And it develops as a progressive onset of seizures, focal with impaired awareness, and bilateral tonic-clonic seizures. It can be one, the other type, or both types. It's initially intermittent, so they develop seizures, that they come in a flurry of seizures repetitively, and then they increase in frequency with a gradual decline in consciousness it varies the period of time over which consciousness declines as the patient transitions into status epilepticus. The patient will remain comatose due to seizures and anesthetic treatment, and systemic complications are common. So this is a nice review by Dr. Gaspard and colleagues published in Neurology in 2015 of new onset refractory status. And in it, the highlights are that 1/3 of status epilepticus cases become refractory in the cohort they described. 1/5 of the refractory cases are actually new onset refractory status epilepticus. They included patients with refractory status who had no etiology defined within the first 48 hours, which is a minority of patients with status. There were 130 cases from 13 centers, and 2/3 were female. 1/3 had a febrile prodrome, so that it gives an idea as to how often the FIRES subcategory occurs. The cause was cryptogenic. No cause was found in over half of patients. And about half of those received immunomodulatory therapies. 19% of these patients, again, 48 hours without a cause, were autoimmune in origin, and 18% were paraneoplastic. 8% were infectious. Complications are common and include neuronal loss, depending on how difficult the seizures are to control and how long they last. Hypotension, which can lead to various other complications, including the use of pressors, line-associated risks, mesenteric ischemia, and acute tubular necrosis. Ileus is common, especially if you're utilizing barbiturates to treat the patient. Skin breakdown, ICU-acquired weakness, and ICU-acquired infections, including sepsis. There are musculoskeletal complications, which may not even be identified if the patient develops convulsive status at the beginning, They may not even be identified until the patient eventually recovers and is able to express pain, or sometimes you can identify these just due to abnormal positioning of the patient, such as a posterior shoulder dislocation. Cardiopulmonary complications are also common, and are listed there. The pathophysiology is thought to be related to pro-inflammatory molecules in the brain. And there are some prospective studies currently looking at these at CSF and serum to try to show that there is a pro-inflammatory cascade in the brain at the time of NORSE. There are already documented increases in IL-1 beta and TNF alpha and upregulation of other cytokines. The reference is here below. There's also thought that genetics related to an inflammatory response may be important. In other words, certain susceptible patients with genetic changes may be more prone to developing an inflammatory response than others. So I'm going to talk a bit about how the clinical course of a patient with NORSE looks, and incorporate into that a proposed or recommended diagnostic algorithm. In the first 24 hours, you'll want to institute your institutional status epilepticus protocol. So this is the benzodiazepine followed by a standard second-line drug, Keppra, Depakote, or phosphenytoin. Get an examination and a non-contrast head CT, the history, which should be attuned to immunosuppression, other immunosuppressive disorders such as hypothyroidism, for example, autoimmune disorders, transplants, and so on and so forth, as well as medications, including supplements, recent illnesses, vaccinations, travel, accidental exposures to animals, insects, drugs, toxins, including certain very rare things like the ingestion of star fruit. You'll want to consider empiric treatment for HSV encephalitis and have a low threshold for empiric treatment until the spinal fluid is back. EEG monitoring, and understanding that continuous EEG monitoring is not the standard of care in all parts of the world, but that if you can do continuous EEG monitoring, it's certainly helpful, unless the patient is already following commands as you treat the seizures. And then a basic CSF analysis should be done in all patients in the first 24 hours who present with this syndrome, including, of course, a cell count, chemistry, gram stain culture, and HSV PCR. And hold the rest of the spinal fluid that you collect for future testing, depending on what these initial studies show and how the patient progresses. Now, just to get into what labs are important, because we really want to be comprehensive in NORSE. They're listed here, and you can find this information at the NORSE Institute website, which is listed above. So that you'll see that there is the basic laboratory evaluation of all patients getting sick and coming into the hospital listed at the top. But also in these patients, consider a porphyria screen, nutritional levels such as B1 and B12, homocysteine, etc. The troponin and CK and lactate are really screening tests so that you'll be aware of what's coming systemically. For example, if the patient becomes hypotensive, you might think of Takotsubo cardiomyopathy, depending on what that initial ECG and troponin show, rather than thinking the patient might be septic, for example. So it can be helpful. CK can warn you that the patient, if it's quite elevated, might develop acute kidney failure or a compartment syndrome. And then I really would always get a drug screen in these patients. Anybody, of course, can be utilizing substances, and it's an low-hanging fruit to find a cause. There are further tests down here in this table, including the spinal fluid testing that would be recommended, and special testing for immunocompromised patients and patients with particular geographic, seasonal, or occupational risk of exposure. Now, when triaging the patient, things that need to be considered as far as indications for admission to the ICU include requirement for anesthetics. You're getting to where you need to treat the patient with anesthetics, extreme agitation, dysautonomia, which can be associated with many forms of NORSE, central apnea, which you can see in NMDA receptor encephalitis, sialorrhea, arrhythmias, blood pressure lability, and movement disorders may all require admission to an ICU. Now, at 48 hours, you'll have a lot of the initial testing back to review and treat any underlying cause you've identified when appropriate. For example, if you've identified by this point cryptococcus, then you would treat for cryptococcal meningitis, which has been, although typically comes with a much more fulminant course that doesn't look like NORSE, it has been associated with NORSE. MRI of the brain with and without contrast, and consider the addition of an MRA or MRV, depending on the clinical history that you obtained, risk factors for the patient. And then at this point, that CSF that you have stored from the initial testing, if the patient is still in status and progressing into a full new onset refractory status, and you haven't identified a cause yet, recommend adding on studies to that CSF at this point and drawing additional serum for the testing listed here. Now, this is the point at which I would have a low threshold to get a CT of the chest, abdomen, and pelvis as well to screen for malignancy, including potentially a pelvic or scrotal ultrasound, mammogram, and to send that spinal fluid for cytology. At 72 hours, if you have identified no cause and you've essentially excluded infection, this is the point at which it's recommended by expert consensus only, not good evidence, to consider initiation of high-dose IV steroids and either IVIG or plasma exchange. Further testing at this stage, if you've not identified any abnormalities yet, of course, your autoimmune encephalopathy panel, that CSF and serum paraneoplastic panels will not all have returned yet, but you may at this point consider additional genetic testing and sending a CSF profile for cytokine analysis. This is where we think the future may be going in this entity, which is to say that we would like to look at enough spinal fluid from patients with new onset refractory status that we understand what the inflammatory profiles are. It would be really interesting if we could say, you know, this is the inflammatory profile of a patient who comes with infectious NORSE versus a patient who comes with antibody-mediated NORSE. And here's how we can target our therapies to those inflammatory profiles. Through the use of things like anakinra or tocilizumab. Immunotherapy, first line includes steroids, IVIG, and plasma exchange. And second line includes rituximab, cyclophosphamide, tacrolimus, anakinra, and now tocilizumab. You can also consider the use of the ketogenic diet, cannabidiol. Hypothermia, I'm not a big proponent of, but there's as much literature there as there is for ketogenic diet. Hypothermia should be viewed as an adjunctive and temporary therapy to try to help get control of the seizures during the very refractory phase. Outcomes of patients with NORSE are listed here. Unfortunately, overall, they're poor. However, a not insignificant percentage of 16% end up with really quite good outcomes. The median follow-up in this study, the reference listed below, a majority of the patients improved over time as they followed the patients. In kids with FIRAS, it's similar. And what they showed in this paper is that 87% of the survivors developed epilepsy. And that's not surprising. And the majority in everybody's anecdotal experience as well has been that these patients develop medically refractory epilepsy. And this was similar in a separate study, 77 kids with FIRAS. 18% of the survivors retained a normal cognitive level, but by far the majority developed refractory epilepsy. There are some ongoing efforts I'd like to encourage everybody to consider participating in to further understand who these patients are, what the outcomes are, how to counsel patients, in particular patients' families, particularly in the ICU phase of the illness, when you're not sure whether they're going to be that patient with a very good outcome or a patient who ends up very disabled with a modified Rankin scale of 4 or 5 and refractory epilepsy. There's a joint project with PSurge, which is a PED status research group that's doing biobanking. There is also above, I didn't mention the critical care EEG medical research group, which is doing the same. They're biobanking through Yale samples from patients with NORSE. And there's a family registry, which is the site is listed there. It's sponsored by the NORSE Institute, and it's being run by somebody out of Canada. That family registry is where the patient's families upload information to the registry. And it is really to get at the family perspective of this disease. And because we don't do a good job of counseling families in this situation early on. There are seed grants from the NORD for $100,000 each, and that's really ripe for the taking. There have not been a lot of submissions for these seed grants. And then the NORSE Institute is something that I would advise everybody who has patients with NORSE to refer the families to. It provides a lot of support to those families. It connects them with other people who have had family members with NORSE and provides resources as well to read. Half of NORSE patients remain cryptogenic. Autoimmune encephalitis is the most common identified cause of NORSE, and you should initiate immune therapy as soon as the infection has been excluded. Outcome is poor at discharge, but improves over time, and a minority of these patients do well. Most survivors develop epilepsy. I'm going to stop there and be looking forward to answering any questions or having discussions about this in the group discussion. Thank you.